of studying every subject and specifically ortho. First, you have to go through all your basics. If your basics are strong, you can do every MCQ. You can solve it by your whatever knowledge you have. Okay. Or if you have not studied till now, you can start studying from basic books, the basic chapters, and the standard books. Okay. For ortho specifically, I prefer you to go for you can go for mostly profit. A lot of MCQs in all India and Maharashtra state or any other state has been asking from the profit. Profit is a book, is a Bible of orthodontics. Okay. So first two chapters like growth, development of occlusion, treatment planning, you have to study from ortho. Mechanical, especially biomechanical factors and biological of tooth movement. These chapters you have to study thoroughly from the profit because a lot of questions is asked from this textbooks, directly taking from that textbooks. Okay. Secondly, you have to go for all previous papers which have been asked since 2000 till now, because a lot of 50% questions has been getting repeated frequently every year. So that 50% you have to thoroughly do it so that 50% you will get it the marks. The remaining 50% is in that 20-30% is very like easy solving. You can solve it by your own mind, and the difficult part is our last 31. Last 30 is the thing which we have studied or related to that you can solve it. So the 70% of the ortho questions you have to you should not do any mistake in that because that's very repeated or easy question. If you are doing the 70% questions properly, there's a great chance of getting in All India rank or any other state rank. If you're doing a silly mistake like marking A and B or you have confusion between the two options, there is a slight chances that you miss other because every single MCQ matters. Every single MCQ can lead to a rank of difference of around 10 or 15 initially. And if you are in a rank of above 100 All India, a single mark can lead to around 200 difference. So that can make you out of the All India ranking. Okay. And other thing I'll tell you, in your pulse, you'll see a last thing, synopsis is there. So that synopsis is very important also. If you are following a single book like Gauri Shankar or Pulse or any other test books, okay, follow a single one. Like you're doing a Pulse, do Pulse properly, thoroughly, okay, or you're doing a Gauri Shankar, go Gauri Shankar thoroughly, study it. Don't go for many books, okay. Many books will land up in confusion because in last time you can't revise all the things, and revision is very important, okay. So study a single book properly, nicely, and study that much you can revise it in the last time. And usually you should do what you do. The synopsis part is there in Pulse. Last few for every chapter, every subject we have like around 5 to 10 pages. What you can do, you can just xerox that page, every chapter, every subject, and you can make a note. You can make a bundle, or you can go over spiral binding and have in your hold. So whenever you are traveling, when you are not able to study, not able to do anything, you're feeling bored, so you can just brush up that every chapter. So that in that synopsis, there are a lot of MCQs that you can go through. Anything you can ask me if you want, like how to study and how to, any doubts about that? I'm waiting for your replies. Yeah, fine. Mail ID will be given at the last. I'll just type it, the mail ID, so that anything doubt, you can mail me the question. I can respond back to you through that mail ID. That's true. Any other thing, doubts for preparation, might you're preparing for now AIMS or 2015 All India or PGI? Yeah, you have to study from the standard books. Like I told you, the Prophet. Some chapters from the Prophet are very compulsory, very surely have to study because the direct answers or questions are taken from the standard books. So we are planning, this paper, auto paper, we have taken from some books like Prophet, Gurukul Singh, some books I have taken. Some questions are from grammar also, so that you can have a view and you can study it for a single line or single page, single MCQ. You can study the full topic. So from ortho, at least is to study Prophet, Graber. Prophet is a must. Second, you can go for Graber, and if you find some difficulty with this, you can go for Gurukul Singh also. Or Balaji. Actually, the values are, there is no standard MCQ book actually. There is no standard book actually. You have to go for like Pulse or Gauri Shankar, whatever it is, but you have to see every answer. If you find any difficulty in the answers, you have to tally the standard books so that you have a standard answer. Okay? There is no standard MCQ books. Sorry. Any other questions so that we can finish this and we can start the lectures of ortho what we have given previous week? Okay, fine. Now we'll start today's lecture. What previously exams aim student published. Yeah, there are a lot of books in the market. If you are targeting AIMS, that you are telling AIMS student has published one book, you can study that book, but it will create more load on you. Okay, might be some questions are asked from that book, might be you can ask. So if you want, you can go for a AIMS. If you are preparing for AIMS, you can refer that book. But All India, I don't think so. You can much question will be asked from that because All India is like both things. Whatever already has are asked, it is repeated, and 30 to 40% questions are new. So that question can be asked from this question bank also. They have some people are telling they have question bank, but I'm not sure they have question bank or not because this AIMS publishing answer is not standard or what it is. I don't know. I have not seen this book, so I'll see this book and I'll mail you. But I'll just put on my mail or in the target site so that what can do about this book. Fine. Okay, let's start our lecture. The first question was, first speech sound learned by an infant are. So in yellow you can see the answer. It is P, B, P, B and M. Usually an infant, when it is born, the first thing he will tell Papa, Baba or Mama. Mama or Mama. Fine. So this is the first sound came by, it is pronounced by infant. I'll tell you about the other sounds also. It is the first infant sound. The second one is C and D. It later appears after the first, like M, P and D. The tongue, it is a T and D is a tongue tip consonant that appears somewhat later in the life, and sibilants such as S and Z that in the tongue tip is placed close to the but not against the palate. Your tongue is close to the teeth and but not against the palate comes in later in life. And last speech, which is R, is often acquired until age 4 to 5. In that case, a slightly difficult pronunciation is there because your posterior part of tongue will touch the palate. So it at age of 4 to 5 years, it is start appearing, acquiring the speech. So the answer is M, P and D. I think this was the easiest one I think. Any doubt you can ask me on the chat box so that I can reply about all the things. Okay. So any doubt on this question? I think it was the simplest one. Everybody knows the first sound of an infant. It is M, P and D. Second question was, the transition from juvenile to adult chewing pattern appears to develop in conjunction with eruption of. The answer is here marked as common in canine. It's a chewing pattern. Okay, it is not swallowing pattern. It's not swallowing. It is chewing pattern. It's not infantile, retain infantile swallow. It is chewing pattern. The question should be seen properly. Okay, so at the eruption of canine at age of 12 years, this transition is there between the juvenile to the adult pattern. Okay, if patient has having an open bite, it will retain the juvenile chewing pattern because canine is likely placed there, and open due to open bite position, it is not able to go for a adult chewing pattern. The third question is, generalized spacing of the primary teeth is requirement for a proper alignment of permanent. Answer is incisor, because usually you can term is incisor liability. You will heard of that in development of occlusion, when there is a transition from the developing dentition, the decidual dentition to the mixed dentition stage. Eruption of the central incisor or incisors is slightly bigger in size, compared to the deciduous incisors. So if there is not a space, generalized spacing is not there in the primary dentition, there will be chances of crowding in the future. So mostly it is spacing, generalized spacing of for incisor, and the term is incisor liability. The difference between the upper decidual dentition and the permanent dentition, it is 7.6 mm in maxilla and 6 mm in mandible. This is a standard value from standard book. You should not refer to any Balaji values, because Balaji values are a lot of wrongs. Wrong values are given Balaji values. So refer standard book for standard values so that you can be corrected in the exam. If you are marking from the Balaji, the values will be wrong and your examination question or all India question will be truly wrong. Okay. You can ask me any question if you would like to for these three questions. Okay, we'll discuss some features about the deciduous dentition. Generalized spacing is normal. Okay. Deep bite is normal. No. 3.5 and 1.8 is a leeway space. Leeway space is different and incisor liability is different. Incisor liability is when the permanent incisor is erupting, the size of incisors are more compared to the deciduous incisors, and the difference of that space incisor tooth is 7.6 mm in maxilla and 6 in mandible. What we're talking about 3.4 and 1.8 is the leeway space. The difference between the dimension, there is a dimension of the canine and premolar to the canine and deciduous molar is in maxilla it is 1.8 and it is mandible is 3.4. Got it? Okay, fine. Good. So we'll move on next question. Dash is the most prevalent form of malocclusion. It's a very simple one, class 1 with anterior crowding. Nowadays you'll see many people having a mild to moderate crowding. Very mild frequency of crowding is mostly seen in every individual. Very rarely is there is a less prevalence of perfectly aligned occlusion in the all over world or all over India, because prevalence is increasing because our jaw is reducing in size and the tooth size is remaining the same. Due to our changes in the eating habits, we are going for soft foods, and due to environmental factors, there is reduction in the jaw and the tooth size remains the same. So tooth material becomes the axis. It becomes so much axis that our jaw is not able to hold that properly. So there is a parietal or labiolingual position changes in the tooth. So class 1 with anterior crowding is the most prevalent form of malocclusion. Okay, with distal step in deciduous transition, the permanent molar may erupt in angles. Its obvious answer is class 2. I'll explain you what about the flush terminal plane, was it mesial step, was distal step, and what they can lead to. I'll show a diagram in the next slide. Okay, here you can see primary dentition and the permanent dentition. In primary dentition, a line drawn from the distal of the primary molar, both upper and lower, with a distal step. First one is the distal step, the line drawn from the upper primary molar to the lower primary molar will give a distal step, and same thing in flush terminal, it will give a straight line, and for mesial step it will give a mesial step. Okay, so distal step will lead to this dotted line. This is transition from the distal step to in permanent dentition. It is due to the three lines are given here. First line shows the minimal growth differentiation. First will show the minimal growth differentiation. Second is the forward growth of the mandible, and it will lead to the dotted line will show the shift of the, finally what shift will be there, it will be showing. First one will show the minimum growth differential, the other line will be showing the forward growth mandible, and the dotted line will show the final position. The first one, distal step, will lead to due to the differential growth of the mandible and due to the leeway space, it will lead to a class 2 malocclusion. And the flush terminal plane can lead to an end-on, or it can lead to a class 1, and mesial step will lead to definitely a class 1, or it can lead to a class 3 if mandible is growing more. Okay, I'll just one more time I'll explain this so that it will be clear to you. For distal step, if mandible is growing normally and leeway space is accommodated properly, so there will be a distal step will lead to a class 2. Okay, if in distal step, if mandible grows to a great extent, it can lead to goes to end-on relationship. If in flush terminal plane, if mandible growth is normal with leeway space problem is if leeway space is accommodated properly, so it will lead to normally to end-on relationship. But if mandible goes more, it can lead to a class 1. In mesial step, same thing. If all things remains normally differential growth of the mandible is normal, it is taken by the leeway space is taken by the lower molar properly, so it will lead to a class 1. Or if mandible is growing too much extent, it will go into a class 3. Fine. Any doubt in this? This is a very important concept. So if you have any doubt, please ask me now so that we can move to a other slide, other question. Fine. I think everybody understood this. Okay. I'll move to the next slide. Next question. If a child has a flush terminal plane, molar relationship early in mixed dentition, about dash movement of lower and molar forward related to the upper molar is required for a smooth transition to class 1 molar relationship in permanent dentition. Okay. So in this, it is answer is 3.5. Okay. What is I told you already, the flush terminal plane. You can see here. The second one, the flush terminal plane. It is in deciduous dentition, the movement of the molar forward or forward of the upper molar, lower molar compared to upper molar is more due to the differential growth of the mandible, and leeway space in the lower arch is more. It is 3.4 mm considering both the sides, and in upper arch is 1.8 mm only. So lower molar movement will be more compared to the upper molar. But how much it is? It is almost 3. To come to a class 1, it needs to be a 3.5 mm. It should be a 3.5 mm. The half it is done by a leeway space and half is by differential growth of the mandible. Okay. From plus terminal, if you want to go a class 1 molar relationship, usually the plus terminal plane, if everything is goes normal by leeway space or by differential growth, it will end up in an end-on relationship. But when it will be in class 1, when the half of the leeway space and half of differential growth is approximately around 3.5 mm, so it will be going in a class 1 relationship, or else it will end up in an end-on relationship. Fine. Okay, we'll move to our next question. Any doubt? I am waiting for a 10 seconds. If you are in doubt, you just let me know. I can clear up that doubt. Very simple concept, and it is taken from the standard book directly from the prophet. So this can be a next question in All India for you. So please note down it. Please note down anywhere like a simple MCQ. Make your own notes so that you can make. Lastly, you can revise it. The important point you think of, you can write in a textbook or in a page so that you can finally in All India exam or AIMS exam you can go through last time 15-20 minutes for ortho. Any doubt in this? Should I move forward? Fine. I'll move to the next question. I think everybody understood till this point. I'll move to a next question. Anything you can put on a chat box so I can refer back and answer you. Next question, according to Prophet, the total rotation of jaw is, according to Prophet, total rotation of jaw is, answer second one, internal rotation minus external rotation. What is internal rotation and what is external rotation? Internal rotation is the rotation of the jaw around the core of the jaw of the mandible. Okay. And what is external rotation? External rotation is a surface changes and alteration in the rate of the tooth eruption. Surface changes in the mandible like resorption, deposition, and when the tooth eruption is there, there is the alteration. There is the alteration of the bony changes. So the total rotation will be internal rotation minus external rotation. Total rotation, and it will this rotation will be measured by a mandible plane angle or occlusal plane angle. Okay, and this angulation is changes around 6 degrees. This total rotation comes to around 6 degrees. Okay, we'll move to a next slide. According to Jog, dash is known as intrametric rotation. Intrametric rotation is a rotation of mandibular plane relative to the core of the mandible. There are 3 types of rotation according to Jog. I'll tell you next slide. First, we'll come to the total rotation. What is total rotation? It is a rotation of the mandibular core to the cranial base. Mandibular core to the cranial base. It is the total rotation. Okay. And what is metric rotation? It is the rotation of the mandibular plane relative to cranial base. Mandibular plane relative to cranial base. You have to just think of this one. Mandibular core with cranial base is total rotation. Mandibular plane with cranial base is matrix rotation. Mandibular plane relative to the core of mandible, it's intrametric. Intrametric you can say in the mandible only. That's so the mandible plane relative to the core of mandible. It is intrametric. Okay. If it is matrix means with plane to the cranium. Total is core to the cranial base. It's a important concept. It can be a 3 MCQs. Total rotation, matrix rotation, intrametric rotation. It has been asked a lot of time in All India, so it should be a better know this and just learn this properly. Understood this till this point? We have done around 8 MCQs till now. So any doubt till in 8 MCQs, so that I can go back to 8 MCQ and tell you something like clear doubts, or should I move forward? Okay, intramatrix rotation. See, just I'm telling you a concept. Just think of intramatrix rotation. Intramatrix will be within the mandible. It is the rotation of mandibular plane with the mandibular core of the mandible. Okay, mandibular plane with mandibular core. It will be within the mandible. So it is intramatrix. Okay, something within is called intra. So within the mandible, changes within the mandible plane to the core of mandible is intramatrix. What is matrix? It is rotation of the mandibular plane to the cranium. It is matrix. If it is rotation of core to the cranial base, it will be total rotation. Understood? Any doubt? Core of mandible is the, you can say the when the mandible is getting formed, the pathway of the infraalveolar nerve, your nerve canal, it is the core of mandible. It is called as the core of mandible during the formation of bone. That is the core. And plane is the external plane that is drawn from the tangent, you can say tangent to the mandible, that is plane of mandible. That's the difference. Clear, or should I explain one more time? I'm waiting for your reply so that I can move forward if you understood properly. Okay, great. Okay, this is the concept you have to remember every time. Total rotation, intramatrix rotation, and matrix rotation. It will be very much useful to you till the end. Okay, so I'll move to a next question. What are drugs? This question is very important. You have to cleft lip, cleft palate. Usually, a lot of questions have been asked on the cleft lip palate in every field, oral surgery, ortho. So this is a like emerging field. So this question will be usually be very much focused in AIMS and All India questions. So everything about cleft lip and cleft palate you should be thorough. So what are the drugs? What are dietary drugs used in cleft lip and cleft palate? Its answer is all of the above: Valium, multipurine, and aspirin. These are the drugs. And I've added some more drugs: Dalentine and cigarette smoking. Can other addition to it can be like a more other drugs which can cause cleft lip and palate. So 5 drugs. It is from profit. So these 5 drugs have to be identified: Valium, multipurine, aspirin. Cigarette smoking can also lead to cleft lip, cleft palate, and Dalentine. Addition to this cleft lip palate, some other drugs are there which cause some other deformities, dentofacial deformities like thalidomide. Thalidomide causes hemifacial microsomia. Thalidomide, if given in early pregnancy, can lead to a hemifacial microsomy, or you can say Treacher-Collins syndrome. It can lead to hemifacial microsomia and Treacher-Collins syndrome. Okay, fine. Usually this tertiary drug usually affect at what trimester? Can anybody answer this? At which trimester? First trimester, second trimester, or third trimester? It is harmful in which trimester? Teratogenic drug. And why? Correct. It is in first trimester because your organogenesis of the your organs, or your say your head or face is going through in first trimester, so it will mostly affect in the first trimester. Very good, very good. Great. Someone asked about spell it please, means like if you want to ask for thalidomide spelling, it is THALIMOD, thalidomide. THALIMODE, thalidomide. It is a drug which has been banned in India because a lot of teratogenicity was seen in this. A lot of child was born with hemifacial microsomia, so it has been banned. Okay, fine. So till now, doubt anything? I'll wait for 10 seconds and move to the next slide. If any doubt, please ask. So I can move forward.